Okay, here we go.
You share the screen.
Yeah. Okay, here we go. All right. So again, we'll do this like we did yesterday. Hang on, let me just. Okay, we'll do this like we did yesterday. If Mehmet, if you could read some of the things that come up on the chat, and if the faculty could, some of the faculty could share, we'll just sort of do a little bit of a discussion. And what I've done again is I've picked one case and possibly a second if we get through the first. But rather than as most case presentations are done, where it's something weird and bizarre that you'll never actually see, I always like to do the cases that we commonly see, and there's a lot of variation in how they're treated, so that we can get an idea of what people think. So here's our first case. This is a 58-year-old male. He has a 1-year history of activity-related axial back pain. It's about 60% back pain, and bilateral it's 40% back pain, and bilateral leg pain, 60% leg pain, 40% back pain. His walking tolerance is currently limited to about 200 meters due to the leg pain. His pain is relieved by rest. He's tried anti-inflammatories, physical therapy. He's used membrane stabilizing agents, and he's had epidural injections. So what investigations do people want? I apologize for my dogs barking in the background.
Please write on the chat, what investigation would you like?
So shall we answer it, or shall we ask the audience?
So
you can read from chat, Mehmet.
Yeah. So, I always believe you should start with X-rays. So here are his X-rays. These are standing AP and lateral. You can see that he has a little bit of asymmetric tilt at 4.5, and he's got a degenerative spondylolisthesis at L4.5.
Right. There are many different answers. Some of them are saying dynamic X-ray with MRI.
Yeah. So dynamic films are commonly ordered for this, but it's interesting. If you actually look, you're actually more likely to pick up an instability comparing a supine study to a weight-bearing study or a standing study than you are with flexion extension. And so actually, if you look at this gentleman's MRI, which I agree you do want to get, you can see that actually he reduces completely in the supine position. So you don't actually need flexion extension films here to know whether this guy is stable or unstable. The other thing to pick up on here is, I don't know whether I don't have a cursor here, but you can see the increased signal intensity in the facets. That's another marker. When you see that, if a patient comes in with who just has an MRI, if you see that finding, you know that they have a mobile degenerative spondylolisthesis. And now here's where I'd like to have some of the board members, the faculty, et cetera, weigh in a little bit. Oh, these are the foraminal views. So you can see very severe L4 foraminal stenosis, a little bit of L5 foraminal stenosis. So
that looks like there is some degenerative listhesis. Huh?
Pardon me?
There is some listhesis, I think, on the MR.
So I can't hear you, Mehmet.
Degenerative listhesis. I see some.
Yeah. It's degenerative listhesis, as Mehmet is saying.
Yeah. Yeah. So what do people want to do? So
injection, surgery, surgery, surgery.
He's already had injections. So an epidural injection at L4.5 gave him about 1 week of about 90% pain relief. He felt really good for 1 week.
That gives us the level of the pain management, pain generation.
Mm-hmm.
But one important point is that injections, there are different types of injections.
Yeah. Yeah. This was done as a transforaminal epidural injection. So with small volume, and so pretty much localized.
I would consider doing also a facet injection.
Because?
Yeah, facet joint cannot be covered with an epidural injection, probably.
Yeah, but what information is that going to give you, or what treatment potential is that going to give you?
You didn't mention it, but probably you could have some signs of pushing the back, and on extension, the patient may feel more pain.
But again, I understand the but how is that going to affect treatment?
No, actually, if a test injection in the facets helps, then you can make a radiofrequency lesion.
But that won't really help with his, I mean, his dominant symptom is his leg pain.
Right.
I agree with Mehmet. I personally, in that case, I will do complete block of that level. I would go with bilateral facet joint and nerve root, and with small volume, as you said. So I will try to completely block that level, and then I will see, because I've seen that there is facet degeneration and open facet sign at level L5S1 as well. So I'm interested to see how much of his pain is coming from L4, L5 and from L5S1.
Well, as I say, he had 90% pain relief with an L4-5 transforaminal injection.
That is very positive sign for me, and that means that his level of pain generation is L4, L5, and I think that level needs to be operated. Because he has leg pain and back pain, I think we need to consider not only decompression, but we need to consider also some sort of fusion surgery.
Yeah.
With all the options based on, what is your preference maybe and what you can achieve. I would personally probably go for lateral approach or TLIF.
Sorry, lateral approach or
TLIF.
Anybody else?
If I would go for surgery, I definitely would go for lateral, because I don't think he needs decompression. So basically, just having a big cage, like Richard Dasaka was saying, and having a good lower segmental lordosis is a good option to me.
Just gonna go
Hey, Doug,
back.
this is, I gave that mid-lift presentation. I think with the facet sign, I'd probably do a fusion here. This is something that with expandable cage technology, I can get a nice lordot, big expandable lordotic cage with cortical trajectory screws, do it through a minimal access.
I agree with
That
you,
would be
Mike.
my
I think
approach here.
that this would be my approach as well. I would not do cortical, but yeah, expandable cage will give me good lordosis.
Would you do a trans-psoas lateral or more like the anterior to psoas lateral?
Pre-psoas for me.
Pre-psoas for me.
Yeah, and you can see here on the sagittal, this is the patient you do not want to do the trans-psoas.
Yeah, Mickey
on.
Mouse sign. Yeah.
This is the so-called Mickey Mouse sign, where the psoas muscle is very anterior to the disc space. These are the patients where the L3 nerve root is at very, very high risk. So this would not be somebody that I would, and actually, I personally don't do the lateral at the L4-5 level anymore because of the risk of the L3 nerve root. And then the other concern I have with the trans-psoas lateral is that would be a tricky lateral to do with the level of his iliac crests.
That's correct.
Possible, but tricky.
Yeah, at the end, the difference between some A-leaf, O-leaf, and trans-psoas is not that different sometimes. You just so.
Yeah. Okay. And we're coming up on our time call. So what I actually did, it's funny, if I were to see this patient today, this is one I did a few years back, or actually about 15 years back, actually. I did this patient as a minimal access TLIF. If I were to do it again today, I would do this as an A-lift with percutaneous screws. I have not gone to the O-lift currently because I've been doing A-lifts for so long, and I do my own approaches for the A-lift that in my hands, it's easier to do.
Doug, what is your choice of TLIF? What was that? From right or left?
I did the TLIF in this case from the right because he had the asymmetric collapse. He was down to the right, so I wanted to jack him up and level off the top of 4 when I did this. But as I say, if I were doing this today, this would have been done as an A-lift with percutaneous screws rather than a TLIF. And my reasons for doing that, three things. One is I get substantially better lordosis with an ALIF, particularly with higher lordosis ALIF grafts. Second, I like the bigger footprint you can get from an ALIF or a lateral. I think it's got a higher fusion rate. When I was doing MIS TLIFs, I was using BMP, so I was happy with the fusion rate, but I had a problem. I had about a 20% acute radiculitis, or about 1 in 5 of my patients that had an inflammatory radiculitis from the BMP. And then when I went away from BMP, my fusion rate wasn't as good. And so that's why I've gone to more anterior approaches like the lateral or the ALIF approach.
Yeah. Thank you, really. It was good to discuss it with the other options. But nobody has said XLIF, I think, or transpsoriatic approach.
Well, we did mention, I think this, as I was saying, I think this is exactly the wrong patient to consider the transpsoriatic.
L4-5,
Not just the L4-5, but particularly this appearance on the axial, where the psoas muscle is anterior, the anterior margin of the psoas muscle is anterior to the vertebral body.
Right.
This is the so-called Mickey Mouse sign. And these are patients where the L3 nerve root is at very high risk. And even the really big advocates of transpsoas would say this is the patient that you should avoid doing transpsoas on.
Thank you, Doc.